Yeah, dear Dr. Almendra, dear Dr. Gonzalez, thank you for inviting me to this meeting. It's a pleasure for me to be here. And as you mentioned, I'm not working in Leipzig anymore. I have moved to Dresden, which is not far away from Leipzig, actually. The task of my presentation is to talk about our experience with a novel, innovative tracking technology, with the Mediguide technology, and that is what I would like to do. These are my disclosures. When we think how we typically track our catheters in the moving heart in invasive electrophysiology, then we have to acknowledge that basically fluoroscopy is still the main tracking technology that we use. This tracking technology has been supplemented and enriched by the introduction of 3D mapping systems, which enabled us to better understand complex three-dimensional anatomies and complex three-dimensional electrical substrates and have opened the door for the treatment of such arrhythmias. Nevertheless, when we think about the workflow and the procedures in our lab, then it is clear that even with this approach of catheter tracking in interventional electrophysiology, there are limitations. And the fluoroscopy is still the backbone imaging technique that we use because it has the one and only advantage that it can track a catheter in real time in a moving organ in a breathing patient. No other tracking technology can do this. The 3D mapping systems that we use are unrelated to fluoroscopy. They stand aside and they only provide static models. They only provide static images. However, our ablation targets and our target organ structure is moving all the time. And due to this mismatch, we have misleading catheter positions, we have inaccuracies in the determination of the 3D position of our catheter tip, and we constantly still need fluoroscopy to confirm the position, and that impacts procedure duration, efficacy, and of course also complications of our procedures. The Mediguide technology, the tracking technology that I would like to talk about, is novel in the aspect that it is the only three-dimensional tracking technology that, similar to the fluoroscopy, can track a catheter in real time. No other 3D mapping system can do this. And this technology is also based on electromagnetic fields, three-dimensional electromagnetic fields, which create a three-dimensional electromagnetic field around the patient, and catheters, which are equipped with specialized sensors, can be localized in this field. The characteristic of this field is a very low intensity electromagnetic field. It's a 200 microtesla field, so you can also study patients with pacemakers and defibrillators. And it is very precise and very fast. The time resolution of catheter tracking is below 1 millisecond. The spatial resolution is below 1 millimeter and 1 degree of angulation. As a further unique feature, this electromagnetic field has been married with conventional fluoroscopy in a sense that the field generators are built into the detector of a conventional X-ray system. By this pre-alignment, we have achieved auto-registration of the three-dimensional electromagnetic tracking space and the fluoroscopic imaging space by hardware setup. In fact, the system has to be slowed down to fit into the fluoroscopy because fluoroscopy typically has a time resolution of only 80 milliseconds. Later on, the technology has also been aligned with existing 3D mapping systems such as the NAVEX system. That means the three-dimensional coordinates are equal to each other. This is all very theoretical. I would like to show you some examples which demonstrates the feature of the technology. What you see in the first movie is a pre-acquired Sinal loop. It's an aerial projection, a pre-acquired Sinal loop, and you see how catheter is maneuvered through this pre-acquired Sinal loop. And the catheter icon here is tracked in real time by the electromagnetic field. You see the catheter icon is in the right atrium. Now it is brought to the tricuspid valve and it jumps into the right ventricular apex. All of this is done without fluoroscopy. The Sinal loop keeps running and the system tracks the catheter in real time. To show you the precision of the technology, now the fluoroscopy is indeed used in the second movie, and now you see the catheters on fluoroscopy, you see the tracking of the electromagnetic field in the icon, and you see they continuously overlay each other. It's really precise catheter tracking. Due to the alignment of the technology with the fluoroscopy and due to the ability to track the catheter in real time, the system allows several compensation algorithms which can recognize primary and secondary organ motion, which can distinguish respiration from cardiac motion, and can compensate catheter tracking for these motion components. And the third movie shows you what happens if the rhythm changes. The patient is now in sinus rhythm, he goes into an atrial tachycardia, and you will see how the tracking changes and also the image display changes. Now the heart is getting faster. You see the sinus loop is getting faster, and the tracking, of course, is again in real time. Which is not so unfrequently a problem in our EP labs is if the patient is moving and the map shifts away and you have to reconstruct everything again. As I said, the system can detect such motion components and compensate for them, and this is actually the last movie on the lower right side. You see now the patient is in sinus rhythm, the system tracks, now the patient moves, the catheters were dislocated, and the system recognizes and compensates the catheter position because the position in the heart has not changed. We have used the Mediguide technology over the last 2 to 3 years in the Heart Center in Leipzig, and these are the procedures that we have performed with the technology. We performed cases of simple arrhythmias, meaning AVNRT, typical atrial flutter, WPW. We performed cases of atrial fibrillation, VT ablation, and also CRT implantations, because CRT delivery tools such as CS sheaths, PTCA guide wire, and subselectors have also been equipped with these sensors. It has to be mentioned that in the first 1.5 years, we only had one catheter available, which was equipped with a sensor, and that was a diagnostic live wire catheter. These are the first 50 patients of AF ablation. Only in May 2012, so almost a year ago, a sensor-equipped irrigated ablation catheter became clinically available, which was then used for further ablation in AF and mainly in VT. And during my presentation, I would like to concentrate a little bit on these fields of indication, because these are the majorities in our labs nowadays. And that is how we typically do the AF ablation procedures in clinical routine when using the Mediguide technology. We place standard catheters in the coronary sinus and the right ventricular apex, as you see here. Then we perform image acquisitions, angiograms of the left atrium, either by a contrast injection in the pulmonary artery and angiogram of the left atrium later on, or by direct injection of contrast into the pulmonary veins. Both is feasible. And these angiograms, these sinus loops, are then used for catheter tracking, for catheter navigation. You see here an angiogram in RAO, an angiogram in LAO, and you see how the catheter is maneuvered through these angiograms. The angiograms are acquired sequentially, one after another, and they are displayed in real time together, synchronized by the ECG in a so-called pseudo-biplane mode. You see in these angiograms, 3D markers can be positioned, which also move together with the heart in real time. These markers have been placed here at the left-sided pulmonary veins. And while the catheter is maneuvered through the angiograms, anatomies in the NAVEX system are acquired to perform the image registration, preparing the ablation procedure. All of this is done without fluoroscopy. All of this is done in the pre-acquired sinus loops. One significant advantage, of course, of the technology is an improvement in the accuracy of the NAVEX system. The field distortions are corrected by the three-dimensional electromagnetic field, and you can see that very realistic anatomies can be created, and the model fusion is performed in the end. As a principle, it is possible to skip this procedural step at all. As a principle, it is possible to create a rotational angiogram, a three-dimensional model which is auto-registered in the NAVEX system, and that is something we request the engineers all the time because it would shorten our procedure. It would make the procedure easier for an inexperienced electrophysiologist if he has already a correct three-dimensional anatomy in space in NAVEX. He does not need to reconstruct any veins, and he does not need to do any registration. We hope that this is a development in the future. Afterwards, the ablation has been done, as you see here. Again, the catheter position is very precisely displayed in the angiograms in the Mediguide system, and it fits nicely to the position in the 3D mapping system. Here, the left-sided pulmonary veins are ablated, and behind the left lower pulmonary vein, the atrial flutter, the AF, terminates. The entire procedure, this was one of the first AF procedures, took 100 minutes. We needed a total of 2 minutes of fluoroscopy time, and the entire staff in the lab took out the lead protection after the transeptal puncture. And this may seem a little bit like a gimmick, but it's not. When we plan our new labs with this technology, we plan them in the way that they're going to be leadless labs, that we have temporary shielding that we can move in once fluoro is needed, then we can take out and work entirely without lead protection. These are the data from the first 80 patients who were ablated with a sensor-equipped ablation catheter. There's, of course, a learning curve. Here you see the learning curve of the fluoroscopy duration. And nowadays, with different operators doing the procedures, we are at a standard fluoro time for a normal AF case around 3 to 4 minutes using this technology, total fluoro time. The procedure duration also has come down to normal values, somewhere around 120 to 150 minutes, and the efficacy is comparable with no increase in complication rates that we have seen. The second topic I would like to target in my presentation is, of course, VT ablation, and that was the first VT case we did with the Mediguide technology. It was a 61-year-old male patient with ischemic cardiomyopathy. He had a chronic occlusion of the left anterior descending artery with an apical aneurysm and an ejection fraction of 40%. He had an ICD and recurrent slow VTs and presented for VT ablation. Similarly to the AF cases we acquire, if it is allowed by renal function, angiograms, images of the left ventricle. That is something that is very well known from the VT ablation from the very first days. We have always acquired angiograms to see aneurysm, to see wall motion abnormalities as potential substrate targets. However, with this technology, we are now able to use these images directly during mapping. We can map in the angiogram, and that's the beauty of the technology. Here it's the LAO angiogram. Now both angiograms are displayed side by side in a pseudo-biplane mode. Here's RAO, here's LAO. You see a very big apical aneurysm in this patient. You see the standard catheters in the CS and in the right ventricular apex. And afterwards, mapping of the left ventricle is being performed. You see the ablation catheter, which comes into the transeptal axis into the left atrium and is then being advanced into the left ventricle. Now the catheter is in the left ventricle. All of this is done without fluoroscopy. Now the catheter is bended towards the septum into the aneurysm. The aneurysm is mapped, and at the same time we create geometries of the left ventricle, which you should see in a second. Yes, here you go. Now the catheter is looped into the outflow tract. It goes up into the outflow tract. You see this nicely in RAO and LAO. Now it's bended towards the outflow tract, and it's pushed forward and opened up over the anterior wall of the left ventricle back to the aneurysm. Again, no fluoroscopy. And you also see the precise anatomies of the left ventricle in NAVEX. It's not the banana shape anymore. It's a real geometry. This was the VT that we mechanically induced in this patient during geometry creation. It was non-sustained. It always terminated during mapping, so we could not do an activation map. So we said, okay, let's go and look for the substrate. We did a voltage map. Here you see the aneurysm being mapped for the voltage map. There's the border zone here, still healthy tissue. There's scar, no potentials there. Now we're coming upwards in the septum, towards the septum, and we map back into the border zone. We can skip this a little bit. Here. there the aneurysm is nicely displayed. Since it was not possible to do activation mapping, we tried to understand the potential circuit of the VT by pacing maneuvers, by pace mapping, and it was very interesting. As long as we paced out of the substrate area, we always got kind of an inferior axis, and that was very consistent throughout the substrate area. Only when we approached the upper border zone within a distance of about 1 centimeter, the axis completely changed to a superior axis, from an inferior to a superior axis. All of the rest was an inferior axis, and we interpreted those findings in a way that there must have been some kind of unidirectional conduction block here at the entrance into the substrate area, promoting unidirectional conduction down through the aneurysm and creating reentrance circuits which basically take the axis at the lower edge of this substrate area. And based on this, we decided our ablation concept. We went for complete isolation of this substrate region, and that is how we validated the endpoint. And this is another beauty of this combination between Mediguide and Nevix. You can pace and ablate at the same time. And that's what you see here. The catheter maps along the lateral aspects of the aneurysm. We pace, as you see in the EP system. There is no local capture. So we assume that the lesion is really complete here. Now the catheter is mapped downwards and more to the septal aspects of the aneurysm, and now you will see how it starts to capture the ventricle. Here it starts capturing. That means there we still have conduction. The lesion is not yet complete. We ablate at the same time while we pace, and you see how the capture is lost during ablation when the lesion forms. This is an acute endpoint of lesion description, which we find pretty helpful in complex ablations in VT as well as in AF. The endpoint is validated on a multipolar mapping catheter. This is a lasso catheter. It's brought through the mitral valve into the aneurysm, and to show bidirectional conduction block in and out of this aneurysm. Now the lasso goes there. Probably the lasso is not an ideal catheter because the risk of mitral valve entrapment, but maybe in the future we will have other multipolar catheter designs. And ladies and gentlemen, also in this case, the procedure took 150 minutes, total fluoro time 1.4 minutes for the entire procedure that I've shown to you. And also in this case, the lead was taken out after the transeptal puncture. We have so far data from 14 patients with VT ablation with the Mediguide technology. These are the mean fluoroscopy times 4 minutes, and all of this was used basically for preparation and standard catheter placement. Mapping and ablation itself doesn't need any further fluoroscopy, and in 9 out of these 14 patients we were able to take out our leads. These were patients predominantly with ischemic cardiomyopathy. These are the patients that are easier to ablate with VT because they have a clear-cut substrate. You don't need to go epicardially most of the time. And the success rate in this cohort was somewhere between 70 to 80% with a follow-up of 6 months, which is comparable to other approaches, so that we assume that safety and efficacy are maintained with this technology. Where do we want to go into the future? I showed to you that the technology offers us the unique ability of real-time catheter tracking, which is only achieved by fluoroscopy otherwise. What we would like to do is have even more realistic models. We would like to have dynamic chamber models which we map, which simultaneously show us mechanical wall motion, electrical activation, and tissue characteristics, just as you see in this animation. This is what the left ventricle really looks like when it contracts, and that is something we would like to have when we study these complex arrhythmias. And maybe the Mediguide technology can take us there in the future. I want to show you one last slide of a study that we are currently performing. It's a so-called wall motion study, and it incorporates the unique ability of motion display of this technology. And you see 3 maps of a patient, 3 left ventricular maps of a patient with a diseased left ventricle with ischemic cardiomyopathy. This is a voltage map, this is a activation map in sinus rhythm, and this is a motion map. You see that this patient has scar areas around the outflow tract down to the septum and down to the apex. You see the spread of electrical activation in sinus rhythm, which starts in the septum and lately arrives in the lateral wall with a time delay of about 150 milliseconds. And then you see how this ventricle actually contracts in the motion map. It also starts contracting in the septum. It has some dyskinesias in the apex, which very well fits to the low voltage area. And it contracts lately, almost lately, at the lateral aspects. However, now with a time delay of 480 milliseconds. We really found this astonishing because it has completely away from the VT, it has impacts for CRT patients. When we think about CRT patients and electromechanical coordination in the left ventricle, these data imply that there is a time delay of 300 milliseconds between electrical and mechanical activation. And I think this is relevant if we think further in CRT patients. On the other hand, these data build the substrate that we need to create the ability of dynamic chamber models, as I have shown to you before. Ladies and gentlemen, I would like to summarize. As today, the fluoroscopy is still the backbone imaging technique that all EP physicians use in complex interventions, because it is able to track the moving catheter, the moving organ in a breathing patient in real time. No other technology can do this. Mediguide is the first one that can reproduce this and even extend it into a three-dimensional space. It tracks in a three-dimensional space, and it can link this space to the fluoroscopic environment. The first clinical experiences that we have show us a dramatic reduction in fluoroscopy exposure with impact on workflows and lab equipment in the future. What we have seen so far are comparable procedure times, safety profiles, and success rates. And this is, I think, an important aspect. All of the benefits are achieved without any efforts. You work in your environment that you are used to. You do not need to learn anything new, an orientation. You work as you're used to with fluoroscopy, just without fluoroscopy. And further benefits that we can also see right now is the catheter visualization in gross pathologies like aneurysms. In epicardial ablation procedures, we can visualize the coronaries adjacently. And I have talked about patient ablate as a very valuable endpoint in our hands, at least in complex ablation procedures. Thank you very much for your attention.